Good afternoon. My name is Ruby van Stein and I'm a medical doctor and a clinical researcher in the Dutch Cancer Institute, Antonie van Leeuwenhoek Hospital in Amsterdam. First of all, I want to thank Dr. Schreuder and Professor Somer-Schecker for giving me the opportunity to tell you all something about the implementation of HIPEC in the Netherlands. Unfortunately, I am unable to attend this meeting, so that's why I pre-recorded this video. If you have any questions, please ask Dr. Van Driel or Dr. Aronson during this webinar, or otherwise send me an email after this webinar. Dr. Schreuder gave a presentation about the OVHIPEC 1 trial, and I will briefly show you the survival curves since this trial is the basis of the implementation project. Patients with ovarian carcinoma stage 3 eligible for interval cytoreductive surgery were included in this trial. The results were positive. The trial showed a significant improvement of recurrence-free survival of 3.5 months and overall survival of 12 months with the addition of HIPEC. There was no significant difference in complications or adverse events, and besides no significant difference in quality of life between arms. Following the publication of the OVHIPEC 1 trial, the national guidelines were adjusted and HIPEC was approved by the health authority, so financial reimbursement by health insurance was obtained. This brought us to the implementation of OVHIPEC with the purpose that every patient with advanced ovarian cancer eligible for this treatment will be offered HIPEC in the Netherlands. Just starting with performing the procedure is not enough. There are many goals during an implementation process. In this particular case, you can think about that HIPEC should be public and accessible to all eligible patients in the Netherlands. HIPEC is nationally promoted to patients, but also to committed healthcare professionals. Clinicians should have expertise and knowledge about HIPEC, and steep learning curves for each hospital executing this procedure will be ensured. Quality of life of patients will be guaranteed. That's very important. And ideally, debulking surgery with HIPEC is performed on a comparable basis across the country, with minimal differences between centers. Besides, by standardizing treatment, complication rate will be low. This is well examined in the surgical community with HIPEC for colorectal cancer. The Dutch Cancer Institute introduced cytoreductive surgery with HIPEC for colorectal cancer in 1995. The treatment protocol was determined in a phase 2 study and tested in a phase 3 study. After completion of this trial, the protocol was refined and implemented in the Netherlands. That was approximately in 2003. In 2005, the protocol started in a second hospital and more hospitals followed in subsequent years. So 3 phases can be identified. The first 100 consecutive CRS HIPEC procedures, that's the pioneer phase, shown in the middle column of this table. The implementation phase started after a completion of the trial and took a few years. And then the 100 most recent consecutive CRS HIPEC procedures, that is the control group, and that's the last column. What they saw in conclusion was a major decrease in morbidity ever since the Dutch HIPEC protocol, standard Dutch HIPEC protocol for CRS and HIPEC was implemented. In addition, the amount of incomplete site reductions decreased. The new HIPEC centers managed to have similar outcomes as the experienced center, indicating that the standardized protocol was a safe guidance for opening a new HIPEC center. And what you can conclude in general is that the implementation of a standardized treatment protocol could result in safe procedures and reduced complication rates. This is also known from aviation studies that deviation from a standardized procedure can be dangerous and can cause accidents. Back to ovarian cancer. On this slide, I would like to present the current situation in the Netherlands. After the completion of the OVHIPEC 1 trial, a cost-effectiveness analysis was performed, which showed that interval cytoreductive surgery combined with HIPEC is cost-effective for this patient population in a Dutch or comparable healthcare system. In 2018, the Dutch health authorities approved full financial reimbursement for OVHIPEC. The national evidence-based guidelines were updated and adjusted with respect to the role of HIPEC for ovarian carcinoma. Patient organizations were involved in these processes and support the implementation of this treatment. In the Netherlands, we have a high level of organization of care for patients with ovarian malignancy, resulting in centralized care for these patients. In each of the 8 regions, 1 or 2 selected hospitals are implementing HIPEC for patients with ovarian cancer, resulting in 10 HIPEC centers in total. In the next slides, I will take you through the actions which we already performed or which we are currently executing. In November 2019, we organized an OVHIPEC symposium in the Antonie van Leeuwenhoek Hospital. This was the kickoff of the implementation project. We invited all members of the Dutch HIPEC teams, involving gynecological oncologists, surgeons, medical oncologists, anesthesiologists, nursing staff of the ward and of the theater staff, since they all plan an essential part in the pre, per, or postoperative treatment. This was a very successful event, and as a result, all the HIPEC teams were on the same page with respect to the desire to fully implement HIPEC in the right way. The next action is about training. After 10 centers performing HIPEC at the moment, 8 already had experience with HIPEC for colorectal cancer and participated in the OVHIPEC 1 trial. They could easily adopt the HIPEC procedure and contribute to the implementation. The 2 remaining centers were trained by one of these 8 centers. Originally, we had the plan for a rotational program to visit and train each center in real life. The idea is that every OVHIPEC center is visited by a team of another center at least one time. Unfortunately, up until now, this was impossible due to COVID, and hopefully we can start this up in 2022. As explained earlier, it is desirable to fine-tune and standardize the OVHIPEC protocol. This will minimize practice variation and will ensure that all patients receive optimal and safe treatment. A survey was conducted in 2019 among Dutch cancer centers performing HIPEC for ovarian cancer. Differences existed regarding patient inclusion for interval CRS and HIPEC, regarding technical aspects of the HIPEC procedure, and regarding perioperative management. As part of the Dutch implementation process, we aim to standardize these important topics using a consensus-based approach. Multiple video brainstorm sessions were organized in which topics reflecting the essentials for pre, intra, and postoperative care were defined. Following this, a Delphi method is used to reach expert-based consensus on these topics. 40 multidisciplinary experts were involved in this consensus. At the moment, we are in the final stage of the Delphi consensus. It is important to assess the outcome of this newly implemented treatment. The results will be carefully evaluated since all data will be entered in a Dutch clinical audit, the DGOA. This is a nationwide clinical audit in which all hospitals will enter all data from patients treated for gynecological malignancy. These data give details and results of the treatment. On a yearly basis, these results are analyzed and reviewed. The aim is to investigate the application and effectiveness of HIPEC in clinical practice. In this way, the external validity of the research results of the OVHIPEC 1 trial will be investigated. We have a few research questions. What are patient tumor and treatment characteristics of patients undergoing interval debulking with HIPEC compared to patients undergoing interval debulking without HIPEC? This hopefully enables to answer the question, did all eligible patients receive HIPEC after implementation of this new treatment? What are the clinical outcomes, for example, surgery duration, blood loss, etc., after HIPEC since implementation in the Netherlands compared to clinical outcomes during the OVHIPEC 1 trial? And for example, is there a difference in the first year of implementation compared to the third year in implementation? And last, what is the recurrence-free and overall survival of patients since implementation, and how does this correlate to the OVHIPEC 1 trial? I would like to end with some future perspective or future goals. Hopefully after an implementation phase of 2 to 3 years, all the goals that I mentioned earlier will be reached. As sort of side effect, it may be possible that this implementation project might lead to a higher percentage of complete site reduction, since there is a closer collaboration with surgeons. And this implementation process might help to improve the quality of the OVHIPEC 2 trial, examining the value of adding HIPEC to primary CRS. Dr. Aronson will tell you more about it later. As you can see on this slide, the implementation project is a close collaboration with hospitals, patient organizations, funders, trial groups in the Netherlands. It's a collaboration of which we are very proud, and we would like to thank everyone being part of this project with the ambition to improve outcome for patients with ovarian cancer. I would like to thank you for your attention. Goodbye.